Welcome to TuriyaTalks, Season 5, Episode 6. Medicines cure diseases, but only doctors can cure patients. A good doctor treats the disease, but the great doctor treats the patient who has the disease. Not only that, a good doctor's comforting and reassuring words are sometimes more powerful than medicines. Coming straight to today's topic of discussion, how to bridge the gap between patients and medicine. We have two doctors with us. One is Dr. Sanjog Kalra and we have Dr. Raj Tayal with us. Welcome to TuriyaTalks, sir.
Namaste. Thank you.
Namaste. Thank you.
We'll play a small video. Welcome to TuriyaTalks once again, sir. So, who is Dr. Sanjog Kalra? Dr. Sanjog Kalra is the incoming director of cardiac interventional services at the prestigious Toronto General Hospital. Not only that, sir is the assistant professor of medicine at the University of Toronto in Canada. And when we talk about Dr. Tayal, he is the director of the structural heart program at St. Michael's Medical Center in New Jersey. And sir is, again, he is a teacher, so he is an assistant professor of medicine at New York Medical College. Sir, one interesting question, I think, why did you choose this career path? What made you beguiled enough to focus and move forward in the stream of becoming a doctor? I would like to hear from both of you.
Thanks. Firstly, call me Sanjog. I don't take myself that seriously. When I think about what drove me to a career in medicine, I realize that everybody has to have a purpose, right? You know, we talk about dharma in, daily life. So when I thought about the type of purpose I wanted to make sure that I had some sort of an impact on the world around me. And looking at what my strengths were, science, communication, and biology, medicine seemed like a natural choice, but ultimately the goal of going into medicine is a very early decision. It's really what you end up doing within medicine that defines what your career is, what your area of specialty is. And for me, I chose what I do now, treating the patients with the most complex of heart artery disease. I chose that as my career because I wanted to have an impact. And when patients are under my care, they're at their sickest. I try to take them as far as I can towards their best. That delta, that difference between the two, that's impact. And ultimately, that's really what we all try to have.
Right. Quite inspiring for people who want to become doctors or people who are forced by their parents to take up this vertical.
If you love it, it's the greatest job in the world. Do it only if you love it, because you owe your patients that.
Absolutely. Well said.
Sir, we would love to hear from you, sir.
So I grew up, both my parents are surgeons. They emigrated and moved to the United States in 1974. So I was born in the US and have grown up over there. But when I finished high school and even in college, I wasn't sure what I wanted to do. I kind of rebelled. I was a snowboarder for a while. Then I went in and did some different things. I did IT for a little bit. But there's real no sense of satisfaction. You can have stock options, you can do all kinds of things that are creative and rewarding, but nothing really speaks to really being intimate and helping somebody else and getting to know them on not a professional level, but on a personal level. Caring for them, getting to know their family, getting to know their family members, what they do for a living. And the sense of reward and the pride that you get in doing that is second to none. So I made a U-turn right after college and went back and did all my educational requirements and then went to medical school afterwards to pursue this, and kind of seeing my parents and the degree of reward that they had gotten from, I grew up in a small town in Virginia. So it was a very small rural community. So it wasn't about money. It was just about having relationships and taking care of people.
Right, sir. I would like to talk about this topic, and I would like to say that, sir, I don't know what happens in US, but if we talk about India And in the past, people considered doctors to be next to God basically. And the doctors treated their patients with full confidentiality and honesty. But nowadays, this relationship has broken down in India, and people are afraid to actually open up to their doctors and trust them easily. What is your opinion? We'll talk about couple of stuff, government regulation, maybe later on as we proceed with the show. But what is your take?
I think the doctor-patient relationship, right? The nature of that relationship, the fundamental basis of that relationship is trust, right? It's faith. Belief that your doctor has your best interests at heart. The other piece of that relationship is a degree of equality in communication. Both people understand the topic that's being spoken about. I think in the old days when physicians were put on pedestals or conceptualized as something that could not be approached, but that was just to be listened to, we were in a different era of medicine. We now use something called patient-centered care, right? Where we focus on helping patients make their own decisions, because ultimately it's patients' bodies, and so it's their choices. The loss of that, I think, has come as a side effect of some of the growth that we've had, where more and more knowledge and more knowledge of diseases, more complex treatments have resulted in more demands on time, shortening the depth of the communication that doctors can have with their patients. For example, if somebody comes in with a complex illness, that individual may want to spend 15-20 minutes with you just talking about what the meaning is of their illness and what the treatment options are, but it's very difficult to do that in a system where you have 50 patients out the door and there is very little support for that kind of communication within the system itself. And I think as we move towards the concept of patient-centered care, we try to bring that discussion back to the middle of the relationship, because that's where you build trust. That's the most important part of the relationship. And we focus on trying to bridge the education gap, the knowledge gap between doctors and physicians, so that instead of talking about something strange that one person understands very well and the other one doesn't understand at all, we try to bridge that gap so that our patients are more informed, they can ask informed questions, and then find it easier to make decisions about their care.
Absolutely right. Dr. Tayal, what is your take on this?
So
I would like to, since you are born there, I would like to know your perspective. What is happening in US as well? You must be having many doctor friends in India. So we would like to get the combined picture from you, sir.
Absolutely. And there are a lot of parallels, but there are also a lot of differences. I work in Newark, New Jersey, which is a relatively impoverished area. There's a lot of poverty, a lot of crime. So with that, there's a lower level of education and a lot of mistrust, because there's a misconception that physicians are, doing this for money and making millions and millions of dollars and just doing unnecessary things. And sure, there's always a few bad apples in any profession. But when you look at the overall healthcare expenditures in the United States, physician salaries are less than 1% of that. So our incomes have been declining readily, but the administrative tasks that we've been asked to perform, the number of patients that we're being forced to see, has decreased. So as a result, when my parents were physicians and still are, but when they spoke to people, it was taken as gospel, because there was no kind of questioning them. Now, as more information is available on the internet and people have this slight mistrust, there's a lot of disinformation on the internet as well. And then when you have the differences and disparities in understanding, when someone is pressured to finish explaining something in a 5-minute time period that may take 30 minutes, it kind of creates a cascade of mistrust and misunderstanding. So I kind of do the same thing with my accountant or anyone that speaks to me about anything. I tell them to speak to me like I'm 5 years old and then add layers of complexity. So I think the internet and different mechanisms have provided a very nice platform or ways of showing people, because there's an old saying that a picture or a movie is worth 1,000 words. So having
Right.
these tools now to illustrate the actual procedure that you're describing, the need, the benefit, has made a very significant impact and change in that relationship, and I think will prove to be a very useful tool for the future, both here and in India.
And just to piggyback on that, so in Philadelphia, while I was in Philadelphia, I was working at a similar type of hospital. We were what they call a safety net hospital, where we served one of the most impoverished communities in the city. The background soundtrack of our hospital were gunshots. But it was one of the most gratifying places I've ever worked, because the patients that come into those hospitals really need care, right? They have nobody. And when you live in an environment where there's danger around you constantly, or you're constantly having to fight for your haq, if you will, which is sometimes the case in India, you become very guarded, right? Your sense of control around yourself and your own body is deeply protected. It's your innate sense. And if the idea of a good physician-doctor relationship is built on trust, and sometimes we have to do very invasive things to people to treat them, then part of the strategy that is most helpful is helping patients understand that even though they're sick and that they're in a hospital, particularly these patients who are used to protecting their control, helping them understand that they are still in control. One of the things that I do with my patients on a regular basis is sit down with them and say, I realize you're scared. I understand that you're frightened, and that's normal. And if I was in your position, that's probably the same way I would feel. But recognize that part of your fear is that you feel like you've lost control. Your body is the only thing you have control over. But understand that you're still in control. You're still driving the bus. And the reason you and I are talking and building the trust that we have is so that you know that you're still in control, and that you're comfortable giving me your voice. My job is to speak for you, to do things that I think are going to be in your best interest within the permission you've given me. And the trust that we have between us means that I'm always there to make sure that I'm protecting your best interests. You haven't lost control. You're still in control. You've just delegated it to me.
One of the points that I'll make there is, I'll give you a personal example where my own mother had a heart attack a couple of years ago. And she was very, very ill for a while, and the doctors would come in and out and mutter 2 or 3 words, and there was no real introduction. You weren't sure which physician was doing what. So even I had a hard time retaining half of what was being said to me. So it's always helpful to have family there and to ask questions. And if the doctor doesn't have time, then ask the staff or someone else, or ask for a reference in terms of saying, is there information that I can read so that I can understand this? Because I think misunderstanding is the fundamental root cause of this divide.
Absolutely. Absolutely.
Sir, how do you think the relationship between doctors and patients has changed from, maybe let's talk about old past days of 1950s or 60s, to modern medicine today, if we talk about?
I mean, modern medicine is focused, I think, more on compiling information and using it as efficiently as possible to solve a patient problem, right? Versus the 1950s, where volumes were lower and complexity was lower because we understood less. So
Right.
as physicians and as patients, both sides are now asked to understand a lot more information than they were before, but the number of hours in the day, the number of minutes in the day hasn't gone up, right? So the relationship has, out of necessity, changed to accommodate more. But for that reason, we as a physician-patient partnership, we have to change with it, right? It's the world changes, we change with the world to be able to maintain that sacred relationship that we have, right? That sacred trust that we have, because that's the bedrock of everything that we end up being able to achieve together.
And to Sanjog's point, in 1950, if you had a blockage in your heart artery and you went to go see the doctor, he'd probably say, or she would probably say, just take an aspirin and go home, there's nothing else to do.
A blanket and a prayer.
as the true word in the literal sense, and that's all. That nothing else can be done. I'm fine. I'll just take my life and be thankful. Now, when we're faced with this option of saying you can take these medications or you can have this procedure or this procedure, it becomes a lot for patients, for families to understand and process and try to decide without fully understanding. So, I think as Sanjog had pointed, patient-centric and care is almost necessary, and that revolves around just education and the availability of information.
You have to start from a level playing field. We all find a great deal of discomfort when we take our car to a mechanic and the mechanic says your fifth cylinder on the left is malfunctioning with a blown gasket and 3 blown seals. We have no idea what they're talking about. All we do is give the credit card and that's it. That's not medicine. That's a car. It has no feelings. It has no personal sense of self. We are people. And so the relationship cannot be one in which one side says, these are the 12 things you need to do, and then the other side hands a credit card. No more than it can be assuming that the person telling you these are the 12 things you need to do has only one goal, and that is to take your credit card. Right? These are not one-sided communications. It's a relationship. The best medical care comes out of a relationship, somebody with whom you visit regularly, develop regular trust, so that you never end up on the dire bed in the hospital. Instead, you end up having your health maintained on a regular basis by someone that you trust, who knows that you're still in control, but to whom you've given your voice.
And emergencies are one thing when something is urgently or emergently needed. However, it's always important to emphasize that having a discussion, if you don't understand everything up front, to say, maybe I can come back and follow up and make a decision. Is there something that I can read, or is there someplace I can get more information to make that decision?
Exactly.
A lot of us have family members, relatives, other physicians. The advent of this dissemination of information through the internet, there's also an equivalent amount of disinformation out there. So having the time to educate yourself and not making a rushed decision, because that translates to mistrust. I have to hurry up and just make this decision. He's forcing me. Let's do this now. It should never be like that. I always tell everyone, go home, read this. Here's a website. Here's a book. Talk to your family. Make a decision. Call me back. So even from a patient perspective, it's certainly reasonable if there's that sensation to say, well, maybe I'll come back in a week or two and then we can discuss this again. Because every sequential conversation you have, you gain a deeper level of understanding. So I think that's another technique that can also help kind of ease that tension and bridge that gap.
I think recognizing that the exception to that is emergency situations.
Exactly.
One of the things that Raj and I take care of a great deal is shock. When patients come in with very low blood pressure because their hearts are failing. Those are true emergency situations where every minute wasted is life being lost. And that's part of the skill, right? That's when you look at medical examinations, standardized exams, the best predictor of how well you will do in medicine is actually your communication scores. It's your verbal reasoning scores. It's not your science or math scores. Because that individual in an emergency, your patient or your patient's family is terrified. They hear only one out of every 3 words you speak. And so as a physician, your communication skills need to be good enough so that in that emergency, your patient or your patient's family believes that you care, and that to you, that's a person, not just a disease, that you're going to recommend what you truly and honestly believe is in their best interests, and that what you're telling is the truth. Right? That relationship needs to be created very, very quickly. And that's why I talk about making sure that people understand that they retain control. When you try to take control away from them, they get very defensive. So make sure they understand that they're still in control, but you are part of their team, not on another one.
Right. We have understood that there is a gap between the doctors and the patients, but going forward, of course, the healthcare players, they have to streamline things. Do you think the introduction of artificial intelligence may help to bridge the gap? Or can we say the use of AI, basically it means that there would be no room for emotions from the doctor because it's all technology?
There are multiple ways of looking at that. There have been papers that have said that primary care physicians are less than 25% accurate in initially making the correct diagnosis in a lot of complicated disease states. I think as we've gone forward in medicine, there's been a lot more of an algorithmic approach to the treatment of patients, which has also detracted from that personalized sensation and the development of trust. If you become patient A that has to go down this cascade of events, it becomes almost robotic. So while I think there are certain merits, of course, in improving patients' understanding and the education of patients, it also detracts from a personalized relationship. So there are benefits, but I think that there are also risks associated with that. So I think it should be used to kind of complement the traditional form of medicine, not necessarily replace it.
Yeah, I mean, I have a similar opinion. I think artificial intelligence is a fancy set of words for something that's pretty basic, right? It's just anything that can support your decision making. The nature of that support can be very complex in its construction, but ultimately, every time you use a search engine on the internet, Google, there is a decision support tool built within that, where based on the previous searches you've made and based on the words that you've used, it gives you a selection of things that it thinks you're probably going to need. But ultimately, as the individual, you're still interpreting the information that comes out. So in medicine, where as patients become more informed, and in part I think because the relationship between physicians and patients has become strained, there's concerns on both sides of mistakes being made or legal action and being sued or whatever, despite a lack of sort of common understanding. And that, I think, is one place where decision supports tools, artificial intelligence, has been lauded by the medical community. It becomes a defensibility piece, right? At the same time, or by the same token, for patients, it helps the decisions being made to have a second set of eyes, if you will, of vetting to ensure that they're accurate. Ultimately, there's nothing wrong with decision support tools. They're great because they allow you to take that large amount of information and filter it so that you can actually make a concise decision. But it all comes down to the interpretation of the information that comes out and how it's communicated to the patient. So a decision support tool can be used as a way of confirming a discussion. For example, you're discussing taking a blood thinner with a patient and you're talking to them about the fact that there are risks of bleeding, but those are weighed against the benefits of the effect of the medication, in this case, reducing the chances you have stroke. And if the patient says, well, I don't want to bleed, you say, well, here's a decision support tool that we can use to calculate what the percentage is that you might have a bleed versus the likelihood that this medicine will save you from a stroke. And through that, the information that comes out of that decision support tool can become part of that communication, part of that conversation, so that the patient knows that your decisions are supported by the best evidence, but also that you care enough to explain how the decision was made and why you in your heart of hearts believe that decision is the best decision for them. Ultimately, our role as physicians is to help patients understand the myriad of information out there and then make good decisions for themselves. It's our duty to recommend a course, but it's your body. So it's your choice.
Right, sir. Tayal sir, would you like to add anything?
No, I think Sanjog did a great job in kind of summarizing a lot of what we've both been saying, right? That it should be iterative use of both personal interactions and communication, but also, as technology is becoming more and more prevalent and readily available for the majority of people, it should be used as a supplemental tool to help educate people to bridge the communication gap and divide.
I would like to share something interesting. I don't know whether it is interesting in whose favor, whether hospital players or doctors or the patients. But India as a country is recently developing various bills that are being converted into acts which basically safeguards the rights of the patients, where they can protect themselves if they feel anything wrong is being done by any medical institution. Now, I think I would like to share one interesting fact. I think in February or April 2017, West Bengal government passed an act called West Bengal Clinical Establishment Act, wherein it empowers the patients and their family members to lodge a complaint against the treating hospital. And of course, in service industry, once they will not be happy with the service, sometimes they would not be happy with the doctor. They can have issues with the nurses, they can have issues with the hospital management. So there are so many categories, and they can go to the authorities. I just wanted to ask you, what do you think has forced the Indian government to take up such preliminary measures for the patient's safety? And adding to this, has the medical field become a place to earn money rather than helping the people? I'm just talking about few institutions. I'm not talking about all the players.
This is now my own personal opinion. Patient safety is paramount in medical care. Okay, it's near and dear to all of our hearts, because ultimately that's why we're here, right? It's to answer the desire to have impact, positive impact. But setting up an environment where you separate the interests of both sides by creating legislation that empowers one side or empowers another side, I think is fundamentally problematic. And my own approach to this would be to roll this back a little bit and ask the question, why dissatisfaction exists, why there exists a divide amongst the physicians or the hospitals and patients that necessitate an organization like the government to create a safety cocoon around patients, right? Are they being abused? Are they being taken advantage of? I have many dear friends and colleagues who are excellent Indian physicians, and I will be very happy to say that you have some of the most talented physicians anywhere in the world in India, truly masters of what they do. I have, both Raj and I have the privilege of going to India on a regular basis and working with the physicians there, doing medical education type of seminars and cases and these kinds of things. It's really a great environment. But I think we're missing the fact that there is no real systematic structure behind patient care. It's a patient pay system where fundamentally then patients become consumers and the care delivered becomes a product. And I think we've illustrated over the last while that the patient care relationship is not about consumer and product. And rather than then create defensibility structures like acts to protect patients when they're dissatisfied, when they may not have the context of what's gone on, I think the question needs to be asked is, how do we change this system so that the incentives for both hospitals and physicians and patients are aligned along the same line? So if, for example, quality of care, how good the care is that you deliver, measured by evidence-based metrics. So for a heart patient, for example, how many patients who come in with a heart attack are discharged on medications that we know save lives and prolong life and reduce coronary disease? How many of those people are referred to cardiac rehab when they leave hospital? How many of those people have been explained their medications and given educational material so they understand their disease? That's the way to measure whether or not care quality is good. And then absolutely, you have checks and balances in place to make sure that if someone is delivering poor quality care, that can be approached through whatever act and structure that you want. But I don't think that it's constructive for either side to arm one group or another with an automatic trump card that says, I'm not happy with what you did, I'm now going to take you to the authorities, because you completely obliterate any chance of building trust.
Right, that creates distrust from the outset, right? Why is that's right. In place? And then the other side is saying, oh my gosh, I don't want anything to be filed in that regard. So there's an immediate barricade to having open lines of communication.
That's right. And I mean, I hate to put it back on the authorities, but let's call a spade here, okay?
Yes.
जब हम अपना धर्म निभाते हैं physicians होने के नाते, तो नींद ठीक तरह से आती है हमें, right? We have no good reason not to do our job. At the same time, I bet you nobody feels more for patients who are in dire straits and who are being asked to pay for their care before they're cared for than the doctors themselves, because ultimately the way we are trained is not to bill. We know very little about money. Okay, the way we are trained is how to provide care and how to provide it efficiently. That's really what we know. And what we hear from the structures around us are, you have to get this, and this done before you can provide care, even though that may tug against our own morality. And so I think it's time to throw it back onto the system and say, the system you have, where you've created an environment that has separated physicians' incentives or hospitals' incentives and patients' incentives, that's the problem. You cannot have a system anymore where patients are asked to pay for their care and then they receive care. If that means that you've got to blow the whole thing up and reinvent a system in which there is a safety net so that emergency care, critically required care, is delivered and funded either by the hospitals, by the state, or both, then fine. The key is rejoin the two important parties in the relationship, physicians or the care providers and the care consumers or the patients, right? By allowing them to build their trust outside of these other problems. That's why the system exists, to be able to support that relationship so that care can be delivered efficiently.
Right, sir. I wanted to share an incident. I don't know if you people would have read that, but there was a video leaked in a hospital in Delhi where dead bodies were being kept with COVID patients and thereby being treated. Now, what happened? The doctors of the hospital, knowing about this, kept the procedure going on without having a little consideration that they have to keep in mind the hygiene factors for those patients until the video was leaked. Of course, I'm not asking you to comment on this. Of course, you were not present here, so you will not be able to do that. But when we talk about bridging the gap, of course, money is an important aspect. So, few doctors, again, do they prefer to take money before they treat their patients, even in utter need? Maybe something like that. Can we put it in something that way?
So, I think that there are two separate issues here, right? So, COVID by itself brought out a number of serious flaws in healthcare efficiency, in healthcare delivery, and its capacity, even here in the United States, where our patient to hospital bed ratio is much, much, much better than what's available in India and some of these other countries with a much larger population, but smaller geographic space, more financial constrictions. But in the tri-state, meaning New York, New Jersey, Connecticut, we were crushed. I mean, we were setting up tents outside of the hospital. We were transporting patients to parks. Our hospital was beyond capacity. Our ORs, our cafeteria even had COVID patients in it. And to the point where our morgues were full. Now, we didn't keep the bodies in the same facility or area where patients were being treated, but we did actually end up having to have cold trailers beside the hospital to store the bodies. So at a certain point, because the turnover was so rapid, it overwhelmed the system. And then when you yourself are putting your family at risk, there's a lot of strains that kind of become unmasked. So I can't speak to that incident. I think it's relatively negligent in that regard in terms of hygiene. But I can certainly understand some precipitating factors that may have culminated into that. Do I think that finance was a preliminary key in that? No, because none of us got paid. In fact, we took pay cuts to still volunteer to go into the hospital and work. So I can't speak to how it translated there, but from my perspective, I can certainly kind of understand if that makes sense.
Yeah, we had a very similar experience in Philadelphia. We were at our hospital. We were the epicenter of the Pennsylvania outbreak, and we were very, very heavy. I had a visionary chief of cardiology who was also an Indian origin cardiologist who really saw the tide coming from the tri-state area and was able to plan our staffing carefully so that we were able to protect one another, ensure that there was adequate protection available. But at the worst of it, it was bad. It was really bad, where we had an overflow of our morgue. We had 80, 90 patients on ventilators in 5 makeshift ICUs across the hospital, where both of our native ICUs were completely full chock-a-block. And people ask us sometimes, were you afraid to go to work, or did you not want to go to work? And to be perfectly honest, I've never felt more like a doctor than I have during COVID. I take great pride in doing critical care along with interventional cardiology, and जैसे कहते हैं ना कि जब अपना धर्म निभाओ तो दिल को अलग सा सुकून मिलता है, नींद ठीक आती है. Right? So I mean, I when I think of the experience that I had as a physician on the front lines of COVID, putting people on life support and ECMO when their lungs had failed 10 inches, 5 inches away from their face, we don't think about the risk that we're under. We take pride in the fact that we're doing something good for society. Building burns and a fireman goes in and puts out the fire. We just had September 11th here in the US, where thousands of people lost their lives, amongst whom were healthcare providers and paramedics and police officers and firefighters. Those people didn't ask that question when they ran in. They did their job because that's their job. And for that reason, I think all of us in this unprecedented time tried our best to do our job as best we could. Were there areas where we could have done a better job? I'm sure there are. But ultimately, we as physicians, hospital administrators, we're all people. We all have the same fears. We all have the same concerns. We all have the same responsibilities. And I think it's reasonably agreed upon across the world that we did the best we could, considering the difficult time that we were all going through. And we have learned a lot about our own system, so that, God forbid, this all were to happen again, we could do better again the next time.
Right. We have got this question from a small nursing home owner that's based out of Asansol city in West Bengal, India. So the person specifically asked if you can narrate few of the actions of doctors done across the globe to influence the gap between the patients and the healthcare system per se as a whole. Of course, you said about patient-centric care.
Yeah, I mean, I think a focus, are you talking, just to clarify, so are you talking about in the setting of Corona, or are you talking about just globally in healthcare?
Going forward, of course, Corona is going to stay with us for next, I don't know, 1 or 2 quarters, I do not know.
However long,
going forward, yes, yeah.
So I think leaving the pandemic aside, because that's a very special beast that requires you to think about the population as a population health enterprise as opposed to as an individual doctor-patient relationship. We go from individual care to war measures care, where we think about the whole more than the parts. In healthcare today, I think the most important movements are educating patients, so giving them access to good, high-quality information that they can use to be informed themselves, so that they can ask informed questions of their health providers, and you can bridge the educational divide so that you're speaking on a similar plane and trust can be built. I think that's a very important piece. I think patients do need to feel, because inherently there's always going to be an educational divide. It doesn't matter how informed your patient is. I think patients need to feel like they are getting good quality care, and that care is based in the best efforts and evidence that we have to offer. And so the use of care quality metrics, ways of measuring how good care is that is being delivered using standard metrics that are validated in evidence and shown to make a difference, that's a very important piece. And then for everybody to recognize that the center of care, the most important piece of care, is the doctor-patient relationship and the communication that occurs. And so the other important thing that's happening throughout healthcare is a focus on patient-centered care and protection of physician-patient communication time, right? Documentation of the discussions that we have, and reimbursement of care based on the utility and the completeness of those discussions. That way, physician incentives are not about how many patients you can treat as quickly as possible, but how well you treat them, how much good communication that happens, how well the trust is that is built between you and your patients. Those three things, I think, will take healthcare, or continue to take healthcare, in the direction that we all hope it goes, where we as physicians are able to carry on long-term, strong relationships with our patients.
Right, sir.
I think there's an important point that medicine, technology, procedures have become more complicated than traditionally. So the relationship by its very nature has become more complicated. So before, it was basically, I say this, so you do that, and that's your only choice. Now, I think patients need to understand, and doctors as well, that they're no longer on a pedestal, and there's so many choices that their job primarily is to educate. So I'll never make a decision directly for a patient. I will help explain the data behind every decision, saying this is the decision for medicine, this is the decision for surgery, or this is the decision for stents, or whatever procedure or not procedure it be. And say, you think about what you feel is best for you, your family. And finances in India certainly become a concern and a limiting factor for a lot of people. But I think understanding the benefits, the risks of medical therapy versus just going and giving somebody, $500 or rupees or whatever for a stent is something that needs to be initiated, if not by the doctor, then by the patient. And asking a question, they shouldn't feel afraid, right? To ask the question, saying, what happens if I choose not to? And if they don't like the answer, we are basically a consumer-driven business. Just like there are millions of people in India, there are millions of physicians too. So while access is a little bit more limited there, certainly getting a secondary opinion with the advent of telehealth or talking to different physicians, I think is another avenue where technology will help bridge that gap and at least improve patient understanding.
Absolutely. Right. It is important for us all to recognize, we said this before, but India has some of the best physicians in the world, right? They're exceptionally well trained, exceptionally intelligent, have fought very hard to get where they are. And the reality of medicine in India is that a system that both sides are in, be it patients or physicians or administrators, is not necessarily built to allow long-standing discussions and patient communication or trust to be built as easily as perhaps as it is here in North America. And that might be the demand, that might be the ask. It's if physicians are going to align on the same side, it is probably with an ask of the larger powers that be, the state, the government level, what have you, to help them create a system in which care quality and the nature of that relationship is what is rewarded, rather than number or rapid decision making.
One last question, tips to patients and their family members during tough times, pandemic times, what they should do. I am saying what the patients ought to do. Even they need to have the patience. Mm-hmm. So any quick tips to them, how they should conduct when they are in pain, when they visit their doctors. Right. So it's not that only doctors who would learn how to conduct, but I think it's the responsibility of the patients too, to have that patience.
So a dear friend of mine, Dr. Abdul Sharkawi, who's an infectious disease specialist here at Toronto General and has become an important voice of reason within the pandemic across North America, has a motto, which is clean hands, open hearts. So as patients, I think it's important for us as physicians, for you as a potential patient, or for anybody really, to take reasonable mechanisms or reasonable measures to protect oneself. Use masks when you go outside, make sure your hands are clean, keep careful hygiene. And in your interactions with others, remember that as a society, we beat this problem. We will not beat it as individuals. And so as a result, keep your heart open. Make sure that when you communicate with your physicians or communicate with anybody, you're doing so with the idea of mutual benefit in mind. Protect one another, protect yourselves. And I think as a global community, we get through this.
The last point I would like to make, though, is during the pandemic, a lot of people, at least in the US, have been reluctant to seek care or reach out to their physicians or hospitals or offices. Medical problems that are chronic, like diabetes, heart disease, they don't stop, they don't go away. So making sure that you continue to take your medications, that you touch base with physicians either by the telephone, by computer, Skype chat, whatever, is critically important, because what we're seeing now is a delayed presentation of people that were sick before but decided not to come to the hospital, and now they're coming in to the hospital in comas or with massive heart attacks that are extremely challenging to treat, and then being put down a road that could probably have been preventable to a degree. So certainly not ignoring care and taking care of yourself is still important despite everything else that's going on in society.
It's exceedingly important, recognizing that,
Seriously,
you know,
I do second whatever you all said. And I think a few decades ago, somebody said the aim of the medicine is to prevent disease and prolong life, and the ideal of medicine is to eliminate the need of a physician. I think before many years ago, people used to take life very seriously, but now they are much more adventurous. So you need to visit your doctors to have that health checkup and routine checkup. But of course, going forward, we all stakeholders have to come together, and we need to bridge up the gap. I think that's how it is. And I would like to thank you, sir, for taking time off from your busy schedule.
thank you very much for having us.
This talk was not only informative for our brain, but for our hearts too. It was a real pleasure talking to you both, and I think it's morning there. So thank you for taking time off. And to our dear viewers, I would like to say that thank you for joining in. Do let us know how you like this particular session and what new topic you want us to talk about going forward. Till then, you can like, subscribe, and press the bell icon so that you don't miss any update. Thank you.
Thanks very much.
Thank you.
Yes. Thank you, sir.
Take care.
Yes,
Namaskar.
thanks. Yes.